Thank you so much. It's very nice to be here in Gdansk. First of all, I think this is really a field where a lot of developments are going on. As Karen and Natasha already showed very nicely this morning, there are a lot of trials going on for adjuvant treatment also in stage 1 non-small cell lung cancer. So my personal guess is that when I would give the same presentation at Agile, the 8th Agile edition, 2031, and it sounds like very far away, but it's only 5 years, that the content of the presentation would be completely different. That said, I have no disclosures. I would like to go back to the basis because I would like to discuss with you what are the current guidelines saying. And then definitions are important. So when we look at stage 1 lung cancer, of course we can distinguish stage 1A from stage 1B, and then we have stage 1A1 up to 1 centimeter, 1A2, 1 to 2 centimeters, 1A3, 2 to 3 centimeters, and 3 to 4 centimeters, or invasion of the visceral pleura is then considered stage 1B. And why is it important to consider adjuvant treatment in stage 1? Because we all know that survival, especially when compared to stage 4, is excellent. So why should we do that? Well, yes, for stage 1A, and especially when you look at the pathological stage, so the stage after the surgery was performed, so when lymph nodes were confirmed to be indeed negative, we see a 94% 5-year survival. But when you then go down, and when you look at stage 1B, which is still considered stage 1, very early disease, almost a quarter died within 5 years. So what do the guidelines say? When we look at stage 1, first choice of treatment is still surgical resection. We had a lot of discussions going on last couple of days with a very good alternative, the stereotactic ablative radiotherapy. Then after the surgery, and especially when the margins are negative, the current advice, according to the guidelines, is surveillance. So currently, there is no systemic neoadjuvant treatment and also no adjuvant treatment currently advised. I think this will change in the upcoming years, but we will see. We need to wait for the trials. Then when we go to stage 1B, still first choice of treatment and alternative is the same, but then we go back, we go further on in the flow chart, and then you have cases where you can consider adjuvant systemic therapy. As was already pressed today, it's very important to test your surgical specimens for at least PD-L1 and ALK and EGFR mutations, since this will differentiate your treatment, so please do so. What options do we have? Chemotherapy, should we give these patients chemotherapy? The guidelines say that it might be considered in case of high-risk features, and that is based on some meta-analysis showing beneficial effect of adjuvant chemotherapy for stage 1B. But it's very important to realize that most of these studies were not based on the latest TNM staging manual. So what was considered stage 1B then is mostly larger than 4 centimeters, and it is now actually considered as stage 2A. When we go back a little bit in history, this is a study published in 2004 from Japan in the New England Journal, and there they tested some chemotherapy for controls in completely resected stage 1, and there you see no benefit for the really what we now call stage 1A, and especially in the group with tumors between 3 and 5 centimeters, you did saw some beneficial effects, but this is mainly for the tumors above 4 centimeters. So actually currently to stage 2A tumors. And what we now know is that we have treatment regimens that, especially for patients with a positive PD-L1 result, have way better results than chemotherapy alone. So what is the role of immunotherapy currently in stage 1 lung cancers in the adjuvant setting. There are two studies that included stage 1 lung cancers, the IMpower 010 and the Keynote 091. And they found beneficial results in patients with a PD-L1 of at least 1% who received previous adjuvant chemotherapy, although I couldn't find the results stratified per stage, so I couldn't see how big the effect actually was in these stage 1B cancers. And then it's important to realize that, again, here the definition of 1B from the 7TNM is used. So this is patients with at least 4 centimeter tumors. When we go back to our definition, 4 centimeters is really like the cutoff between 1B and 2A. So there are some of our 1B that do meet these guidelines. We also heard about TKIs. Currently, the only therapy adjuvant that is recommended in the guidelines for stage 1B tumors is osimertinib, because it was tested for tumors of 3 centimeters and above. So when we really strictly look at the guidelines, the only recommended therapy is osimertinib adjuvant for non-small cell lung cancer with EGFR exon 19 or exon 21. Alectinib is advised for tumors of at least 4 centimeters. So here again, you are at the border of the 1B and 2A stage. I can go very briefly through this because you've already seen this morning, but these are the results of the ADAURA trial where the adjuvant osimertinib advice is based upon. And when you look here, I show you the results for only the stage 1B cancers. And you do see also in the early stages a very beneficial effect for the osimertinib versus the placebo. And what I personally do think is that this probably can also be applied to even earlier stages, but we need to await those results. And similar findings for patients with ELK mutations in the ALINA trial. This is also, again, only the stage 1B, but here the cutoff is 4 centimeters, so currently the stage 2A cancers. And again, even the numbers are low. You see beneficial effects of adjuvant alectinib, and I can imagine that that also in even earlier stages, this beneficial effect will be confirmed in the near future. We already talked also today about circulating tumor DNA. There are 2 ways you can use your circulating tumor DNA. First of all, in the diagnostic stage, if you have a very early stage 1A lung cancer and you find a positive ctDNA, you might consider additional workup. Are you really sure that the lymph nodes are negative? Are you really sure that you are dealing with a stage 1A tumor? On the other hand, there are now different trials, including the TROPION-Lung12 that was already referred to this morning, going on to see if you can use ctDNA to guide your adjuvant treatments. So if you find a clinical stage 1 with a positive post-operative ctDNA, these patients in these 3 studies are randomized to either surveillance, like the current standard of care, or additional adjuvant treatment. And I think we should await these results. Then lastly, this is something we currently do in Amsterdam, and it comes from the melanoma world. I think more developments and treatments that we give in lung cancer had their first developments in the melanoma world, is the injection of a low-dose intratumoral immunotherapy or intralymph nodal immunotherapy. This is all very preliminary, and although the first results for the melanomas are promising. In this safety feasibility trial, we do after a first navigation bronchoscopy with the confirmation of non-small cell lung cancer diagnosis, and very important also a concentric radial EBUS sign, so that you know that you're in the middle of the tumor, as you see in the middle. After diagnosis of non-small cell lung cancer, and if you're sure that there are no EGFR or ALK mutations, we inject intratumoral tremelimumab 10 to 14 days before the resection. And we did now like 10 cases, and the pathology results are very interesting. So officially it's still blind, but we do find some very interesting pathology results. So we have some ideas for which cases we did treat with intratumoral immunotherapy. So I'm very enthusiastic about this development, and we'll see what future will bring. So to conclude, currently at this moment there's no adjuvant treatment indicated for stage 1A non-small cell lung cancer. In stage 1B, always test for PD-L1, ALK and EGFR, and we should also consider probably, especially for research purposes, to test it also in the earlier cases, as we discussed earlier today. For stage 1B, smaller than 4 centimeters, there's currently no evidence on adjuvant immunotherapy, except for patients stage 1B with an EGFR mutation and patients with a tumor around the 4 centimeter border. Thank you for your attention.